of issues, 4 or 5 issues we would like to discuss. We decided on not taking questions from the audience, given that it's a very large audience, but I assume that a number of the panelists might also be at the reception later on and might be in the opportunity to discuss things with you or take your questions later on. I'm not going to introduce each of the panelists. They will do so in a moment, but I'm happy to say that we are very proud and happy to have this highly qualified ensemble of panelists who come from different areas, actually. I'm just going to name them, and then I'm going to ask each of them to present themselves and give some first thoughts and reflections on the presentation given by Dr. Clark. So from my left-hand side, we have Mr. Gorik Kaesemans from Zorgnet-Icuro. We have Marleen Finoulst, who among other things is a member of our Belgian Center of Evidence-Based Mental Health. We have Professor Jeroen Luyten from the University of Leuven, who is a health economist. We have Professor Pierre Philippot. He's a clinical psychology professor and also member of our Federal Council of Mental Health Professions. Professor Clark will be part of the panel, and Harmen Lecok, who is a prime advisor of our Federal Minister of Health. Can I start with you?
Can I just say something about that? One of the points on one of my last slides, which I didn't explain, it said make friends. So and it is really important as professionals for us to understand that it's good to make friends with everyone, but if you're trying to advance mental health, there are 2 types of people that you really want to reach out to and have friendships with. One is economists and the other is politicians. And they're both human beings and they're both very nice.
Okay. Harmen, can you start by presenting yourself and give some...
To talk with him and understand his views on topics which are very important and very accurate and talkative in the Belgian policy right now. I think it's beautiful to see that it's possible, to create something new, create something special, data-driven, evidence-based, all the things that we have dreamed about. Actually, they did it in the UK since a couple of years, started in 2006 with a pilot, and then elaborated each year from 2008 onwards. So I think that's just beautiful to see, and I hope that we can have a debate, positive-driven on that experience.
Thank you, Harmen. Pierre?
Okay, so I'm Pierre Philippot. I'm a clinical psychologist and psychotherapist, and I'm teaching clinical psychology and psychotherapy at the University of Louvain in the French-speaking part of Belgium. I'm very, very excited by this event, actually, and I think it's a very, very timely moment to discuss all these things. Things are changing much more rapidly than what I was expecting 10 years ago, and I'm so happy about this. We will discuss it, but it has implication for our professional cooperation of psychologists and psychotherapists, but it has also deep implication for training. I will be very happy to discuss this with the panel because really things has to change there too, and we are in a university which is at the forefront of promoting evidence-based treatment, and I think there is still several steps to be carried forward.
Okay, thank you. I'm Jeroen Luyten, a health economist at the Leuven Institute for Healthcare Policy here at KU Leuven. What struck me most about the presentation is that economists are typically people who are the bad guys in a discussion, or we also called the dismal science, because it's very often a cynical message that we have to bring, that there is not enough money, and very often in health that's the case. Where we have a small child that needs a very expensive drug or something, and then the economist has to say, well, we can't afford this or that. But in this case, it's actually a great panel to be in because it's a win-win for both sides, because the economic case is so strong and the medical case is so strong as well. So we're sort of natural allies, I would say. And yeah, it makes you wonder what are the barriers that keep these programs from being implemented. And that's what we need to focus on, I think.
I am Marleen Finoulst. I'm a general practitioner, in fact, a former general practitioner working now at the Belgian Center of Evidence-Based Medicine, not mental health, but medicine. And what we do is looking at guidelines for GPs, distributing guidelines for GPs, validate them, and train GPs to use evidence-based guidelines. And I think it's wonderful, and I think the EAPS program is really a wonderful program. We should do the same on psychology as we are doing on medicine in the last years. And training psychologists to use the guidelines is certainly one topic that I like to discuss with the panel. And also, well, we have some elections coming up in a few months, and I heard that it's a time to... I see some politicians here as well, so we should talk to them and tell them, wow, you must use these things and these programs. It's a wonderful thing.
Thank you. I'm Gorik Kaesemans. I'm a member of staff at Zorgnet-Icuro, and it's a Flemish Federation of Healthcare Organizations. So we represent all general and psychiatric hospitals, organizations in elderly care, and also the whole range of mental health care providers, like, for example, the Center for Community Mental Health Care. So, like Tine, one of my first reflections when I read the book was one of admiration. I was clearly impressed by the thorough and well-documented business case that clearly proved that an impressive return on investment. And I'm also very charmed by the clear description of the roadmap which is needed to get the job done. So, like my colleague said, we are on our way to elections. There is a clear description of the roadmap that is needed, and I really hope that we will follow a Belgian roadmap to this kind of program.
Okay, thanks. The first topic that I would like to embark on is the topic of the implementation gap, and that was already mentioned. So the implementation gap is the difference between what do we know about what works and what do we do. And that was actually driving the whole IAPT program in the UK. Looking at Belgium, what do we actually know about this implementation gap? How far are we in having the directives, like the NICE directives? How much are clinicians informed about what works? And how much are patients informed about what works? So that would be a first topic of discussion. So, Marleen, is that a question maybe for you?
Well, I can talk about what about medical guidelines, and we do have for general practitioners 1,000 medical guidelines available, made available by the government, paid by the government. We have summaries of all these guidelines, 1,000 in German, in Dutch and in French, and the guidelines also can be. There is an access from when the patient is consulting his GP, he can immediately go through his software, his medical software, to the guideline database. So that makes it very available. To stimulate the implementation of using guidelines by GPs, they get an incentive, a financial incentive, since a couple of years, and we see there is a doubling. The GPs that use clinical guidelines doubled. We have 5,000 now. I looked up the last data for the panel here. 5,000 GPs that really use the guidelines, and we have 16,000 GPs in Belgium. And for the patients, another thing is that we make in CEBAM, the Center of Evidence-Based Medicine, we have a platform for patients called Gezondheid and Wetenschap, and what we do there is translating all the guidelines for GPs to the patient. So the patient as well knows from, this is a guideline, I have, for example, this disease, and I see what is the evidence behind it. What should my doctor do? So that's another push for the doctor to use evidence. So yes, I think you need the incentives. You need to train the GPs to use evidence-based guidelines, as Professor Clark mentioned as well. You have to train GPs. Where do you find the guidelines? Easy, accessible, and then available in the proper language, perhaps, and a financial incentive is helping as well. We have 1,000 guidelines for GPs, and there are, for example, for depression, 6 guidelines for GPs. And the guidelines, what do they say? For depression, for example, psychological therapy. You start with, but the GP is not trained for that. I don't see any guidelines for psychologists in Belgium. I don't know if there are any.
Well, when we have to refer to guidelines, we are using NICE guidelines. Thank you very much to the British for that. But it's the guidelines we are referring the most as psychotherapists or as psychologists. But still, I think there is a big gap. And one gap that has not been mentioned yet is the misconception that a lot of, not in the public, but in the professionals, the misconception that professional psychotherapists and psychologists have of what is evidence-based treatment and evidence-based practice. And there is a lot of people, professional, who disagree almost philosophically with this approach. So this is something that's really needed to be worked in Belgium. I don't know, I think the situation is different from UK, where evidence-based practice is much more commonly agreed upon by the professional. In Belgium, I think there is still some resistance about it. And even for people who adhere to this perspective, there is the problem of proper training. Some type of treatment really requires certain, not only professional skill, but also personal skill and guidance and supervision. As a supervisor, I often see, for example, a very common thing which is widely recommended by the NICE guideline, which is exposure therapy. Exposure therapy that is not properly done by people who want to apply evidence-based treatment. So for me, there is a gap, an important gap. We have to recognize it. We have to recognize the problem if we want to go further to the problem. And this gap is sustained by at least 2 things, which is misconception about what evidence-based practice is, not in the public, but in the professional. And also proper training and proper supervision and ongoing training of the professionals.
Okay, thanks. David, you want to?
Yeah, could I mention something about guideline-based treatment, because it's quite relevant. So I think some people don't like the idea of guideline-based treatment because they think it's like following an American manual. So there are lots of sort of CBT and other therapy manuals that were written for clinical trials, but they're sold as books, and it says, it's session 3 you do challenge shame beliefs, it's session 5 you do this, and it's session 7 you do that. And obviously, if you're trying to follow that, then it's really a straitjacket and not very good. But that's not really what following guidelines is about. Following guidelines is more like doing a proper individual formulation of the case and then drawing on the different procedures in the guideline in a flexible way to fit that formulation. And there's a very interesting transatlantic difference in outcomes that may inform this. So in North American studies, when you look at older people and you look at CBT for anxiety and depression, they tend to do less well than working age people. And so much so that some people I know well in the CBT field say, well, maybe we should have more medication for older people, which doesn't really help us. They get very confused with it. But in the IAP data, we actually get a recovery rate of 65% for people over the age of 65, and 50% for everyone else. So actually we're doing better with older people. And I think the reason for that is that in the English model you have this very individualized formulation and then drawing on things that fit the formulation within the guideline, not rigidly doing session 2 this, session 4 that. And I think older people just hate that rigidity.
Thanks. Maybe a specific question. NICE has produced these guidelines, but NICE is not the only institute in the world that has produced guidelines.
Yes.
In the Netherlands, we have Trimbos Institute and so on. And in Belgium, these guidelines have not been created so far. Should every country create your own guidelines, or can we translate and borrow from other institutes? Is that, Marleen, something that is feasible?
Well, we use for GPs in Belgium Finnish guidelines, and we adapt them to Belgium, to the context of Belgium. So it's true, it's not possible to develop guidelines in every country. I don't think it would be a lot of loss of means. So we can adapt guidelines from abroad. I think that's what we do for GPs.
I can confirm that assumption, and I would like to add that it would be a great idea to get buy-in by professionals, to let them participate as much as possible in the adaptation. So we need some change management also within the minds and hearts of professionals. So just don't copy-paste or translate, but do an adaptation and use the power and the knowledge and the experience of professionals, of Belgian professionals, to do the adaptation.
Maybe a last question to close this part, and Harmen, maybe you can comment on this. Given the change of situation for clinical psychologists under the new law, do you think that this has also an impact on the extent to which new guidelines are necessary? Or that new responsibilities arise and it has an impact in that way?
The visibility of clinical psychology in healthcare will be exponential the couple of years coming, I think. You already had 20 years, 30 years a visible place in healthcare, but there was no recognition of a law. You were just actually in a very empty space. Visible, but no recognition and no responsibility. I think that's a big step that we took. And regarding the guidelines, I think, again, the fact that it's easy to say you have guidelines and then you can just take them and then the results will come automatically. That's much too simple, I think. And I think the truth will lie in the middle between Gorik, it's part of implementing or use the professionals themselves, and the fact that foreign countries that already provided a lot of guidelines who are empirically based, why question them? I mean, it's the truth is in the middle there, I think.
Okay, thanks. If that's okay, I would like to start with a new topic, another topic, and that is, and maybe I can refer to part of your story, David, when you said, well, when I was a young researcher, I thought, well, if I do the randomized control trial and I publish about this, I can go on holiday and the rest will start. But apparently it doesn't work like that. David Barlow in the States, he says, we should take a completely different approach. We should do direct-to-consumer marketing, which actually is the approach that pharmaco companies are using. So they make the public aware about what works and what is helpful. And so it's the patient who goes to the psychologist, to the therapist and says, I've learned about this drug or this treatment that works. Please deliver it to me. So the push, it's not pulling the clinician, but it's the patient who pushes the professional. Is that a good approach? Are there other ways to bring this knowledge to the patients? And is that the way to go, or are there other ways to bring evidence-based practice to the forefront?
I think it's certainly one way to do so, and we have launched, or the Minister of Health launched a year ago a platform, mijngezondheidbelgië.be, masantébelgique.be, where people can look at their personal health records. They can see when the GP or makes loads up the summary of the dossier, so people can see their health records, can see what happened, what the blood results are, so if they are vaccinated, if they should be screened or whatever. So it makes public aware of their own health, take it in their own hands. It's patient empowerment, how we call it. So they can go to the GP and say, hey, shouldn't I need this screening, or shouldn't I do this? So it helps when you make people, when you address directly to patients or people or population, they can go with good information. Then yes, it can work. So that's why we also translate to make accessible all the guidelines for GPs to the public. So one can take a printout of the guideline in language, popularized language, so that's understandable, and go to the GP and say, I don't need antibiotics for this, so why do you prescribe it? So yes, it can help. I think it can really help.
Yes, well, I think this question also relates to the previous one on the implementation gap. In a way, it is indeed special that you see such a big difference between what is technically feasible and what's actually being implemented. And I think as an economist, you would look at that from a supply and a demand side, and there's clearly insufficient awareness of people of what these benefits of psychotherapy can bring to them. So I think that's a first main message, is that people need to be aware of the effectiveness of these treatments. But on the other hand, there's also the supply side, where as a benefit, as one of the consequences of being a health economist is that you see the whole spectrum of healthcare asking for money. And so then you do see that pharmaceutical products are being marketed much more effectively, and there's much stronger lobby groups behind supplying particular products. And I think also there's also from the supply side perhaps a bit of a problem in pushing forward the real effective programs in mental health. And on top of that, I also think that even then, when we manage to bring about or convey people of the benefits of psychotherapy, even then it may still not be enough. And then we see that in the case of vaccination, for instance, as was said before, where there's also a clear benefit, and still people are a bit reluctant or hesitant to use them. That might be the case in psychotherapy as well, where there's a certain resistance to making actual use of all these benefits. And then there is perhaps an interesting literature to be found in the whole behavioral economics literature, where they use all kind of techniques, and that comes very close to social marketing, I think, in promoting these benefits for both sides.
I think we have to invent our own model. I don't think the pharmaceutical company model is the right model to follow, because it has a lot of adverse side effects. It has not always been to the benefit of making good treatment accessible to the greater number. I think in psychology, most of the treatment are totally free access treatment. There is very few people. There are some people who try to have copyright on certain type of treatment, but they have been long lasted. So we are not selling a product. We are, how to say, making available some expertise in a specific domain. And this is very different from selling pills or selling very expensive apparatus that are now needed by modern medicine. So I think we should not be inspired by the pharmaceutical model. also, if we do some marketing and we need to find our own way to do marketing, we have to be sure that what... Sorry?
That's it.
Okay, oh, I'm sorry. Okay, oops.
Whoa.
No. If we start to make some marketing, we have to be sure to be ready to answer to the public demand. And I think we first better be prepared to be ready to answer to the public demand. And a last comment, maybe it's a bit provocative, but I think we have been, as a profession, psychologists and psychotherapists, we have been very, very bad. We are in big part responsible for maybe a negative image that the public has of our service. We have spent so much effort and stupid energy into fighting among each other, among different schools of psychologists. And I sincerely hope this is really behind us. And we are, first of all, psychologists, not CBT or psychodynamist or whatsoever. But we have to recognize that we have a big responsibility here. And that's very sad, because of that, a lot of people do not get the proper treatment because of a priori and representation that has been built in part on because of our own stupid behavior as a profession.
Yeah, I like to enhance that thought. I think we spend a lot of time in fighting each other, and when you look at some figures and facts and figures in our country, for example, on the use of medication, antidepressiva, it's the cost is 470 million each year. 1 million countrymen use it, so it's more than 1 out of 10. So the selling of pills really does work, and the selling or making clear to the public that there is an alternative that works better, we don't manage it at this time, at this point.
Okay, David?
So obviously you need to build the capacity before you advertise too much. But I think in England, I think what's happened is that we're on a journey which is about 30 years behind cancer. So about 30 years ago, with cancer, people didn't like to talk about having cancer. In England, they used to talk about having the big C. They didn't even want to mention the word cancer. And of course, the reason for that was that for many people, it was a death sentence. There wasn't much that was going to happen. And so what's the point of talking about it? But of course, things have changed with many cancer treatments, and many more people survive now. And so many more people are willing to talk about it. Well, I think IAPT in England is doing something similar. Now, because the outcome data is recorded and reported, many people with mental health problems now know it is possible to recover, or it is possible, if you come forward to treatment, to get much better. And so, of course, there's much more willingness to talk about it, and much more willingness to come forward for psychological therapies. And that's a sort of fundamental shift, I think, because mostly, people felt a sense of stigma and didn't want to talk about it because, what do you get from talking about it? Nothing, sort of thing. So that's really another reason why, in mental health, as reporting outcome data is so critical, because it changes public perceptions. Now, I think, because we're building capacity, Public Health England is about to launch a very interesting initiative called Every Mind Matters, which is a public health campaign on mental health, which will raise awareness of mental health problems in general, but not all just the clinical severity ones, the full range. So the campaign is really alerting people to anxiety, depression, and other problems, and giving people some simple advice on the internet to manage mild problems, but also explaining, and if that doesn't work or it becomes very severe, then you can refer yourself into IAPT. So it's again a matter of giving people a general sort of understanding of mental health issues, normalizing it, not making everyone think that they should go for therapy, but allowing those people who really need it to feel they can seamlessly enter it.
Okay, thanks. It's not only about informing possible patients, it's also about informing politicians. A day like this is part of informing politicians, and there are other initiatives that you can see. This was one of the major steps that you have taken, David, in launching the whole cycle, is the connection with politicians. Harmen, you as an advisor with many years of professional expertise in this domain, how should we go about informing politicians? You know, you're not a politician, but you have the expertise.
Becoming my friend, apparently. No, but maybe, I mean, this is the question, I think. For me, this is the question of the debate, of course, because I'm not a clinical school person, so I have to keep my mouth shut when it comes to that. But this is the question that you can actually direct towards the economists and the politicians at once, I think. Because let's address the elephant in the room and the fact that you were all murmuring in the beginning. The fact that we got a lot of criticism about the pilot and about the first step of reimbursement of psychological care in the primary care. Because I understand a lot of those criticisms, of course. I would be blind and deaf if I wouldn't understand them. And that's why it's called a pilot most of the time. And I think and I hope that we can evolve towards better support in the coming of years. But although those criticisms towards policy choices regarding an amount of money or regarding the obligatory cooperation with a general practitioner is totally valid and understandable, in the slipstream of this criticism we heard, we found, and we encountered a lot of things that really struck our cabinet as odd, and that is that the short-term intervention that I think IAPT and everyone and the WHO already 20 years supported, was put into question as well. And then there was a lot of not understanding the criticism anymore. Because if you talk about the amount or the cooperation with the GP, that's okay. If you don't agree with it, that's okay. Let's do the pilot, and if the choice was wrong, then we will be wrong, and we will be put on a place. And yeah, that was a wrong choice, Margie de Blok. You were wrong. But saying in the slipstream of that criticism that it's not a good investment in primary care, and that the short-term intervention is not the best option, well, that's stupid. That's very, I mean, you undermine your own position as a field. Because then everyone in our cabinet was saying, yeah, but they have also criticism about the investment itself, about where should we invest. And that's weird. I mean, if that's the criticism as well, then there will be no political support anymore, I think. Even from other parties.
Yeah. I think the best way, Harmen, is direct communication and not always via the media, but
media is a good. I mean, we also use media. We all use media. We all have butter on our head. Is that also Flemish? That's not no. You got me. You got me. Yeah. So we also are very. I mean, we're all vulnerable to media. So I mean, that's not a criticism I wanted to give.
Yeah. Okay.
Well, I like to refer to the roadmap in the book by the professor, and the fact that there, at some point in time, there was a small step taken, an experiment in 2006-07, and it was a first step to make a much larger step. When you look at the agreement political parties made by the start of this federal government, it was quoted that they would examine the possibility of reimbursement. So they do more than that. And it doesn't often happen. It doesn't often happen that a government does more than it is quoted in the things they agreed by the start of their term. So it is a small step. And it is in effect, maybe of course there is more budget needed and there are other steps needed. But I was in this beautiful town 25 years ago starting to study psychology, and there were several professors at that time. They are not around anymore at this point, and they told me within 5 years from now, or 2 years from now perhaps, there will be some investment in. It's 25 years ago. They already told me then. Now we are at this point, so I really hope that we could take a small step, learn from the pilot, and take next steps.
In the interest of time, I'm going to handpick some questions myself here. The ones that interest me most. Those are specific questions. One maybe for you, Jeroen, as a health economist. One of the issues is, how much money do we need? How many people do we need to train in a country like Belgium? We can compare the 51 million people in the UK, something like that, 12 million in Belgium, we can divide it by 4, does that work? You as an economic person, can you bring together a team and can you calculate, do you have enough data to calculate how many clinical psychologists we need, how many therapists we need, how much money is needed, for instance, to cover 15% of the population that is in need for direct treatment for anxiety and depression? Is that, or do we need data, extra data?
Well, that's a lot of work for one economist, I would say. But and also it goes beyond economics. It goes beyond the discipline itself, I guess. It's a matter of planning, health policy planning, and calculating how many people you would need. That's probably a similar exercise as calculating how many doctors we need every year, or how many students can start in the program, the medicine program. Well, it must be possible, definitely, but to really calculate a good number of the real need of how much money we would need to invest as a society in mental health care, I think that definitely requires a lot of data that we don't have at the moment, and also not just data, also methods of to calculate a sort of an optimal number. We would need to gain insight in all these secondary effects that Professor Clark has told us about. So not just the effects of treatment, but also the knock-on effects on physical health, for instance with diabetes patients, as was said before, but also effects on productivity, how people react on the labor market, how absenteeism, presenteeism, and what's the value of that. So it requires a lot of very hard to quantify outcomes. But yeah, there's definitely estimates possible, and in a way it must be possible to calculate an optimal size of mental health care. But I think it's clear that it needs to be bigger than what is currently the level of investment. And then maybe that brings us back to the previous point as well. It's a competition for resources in a way. Yeah? So between mental health and other fields within healthcare, there's a limited budget, needs to be allocated over all these different parties, and they all make their claim as strong as possible. So it is a matter of showing your benefit, I guess.
Okay, thanks. Cool. You wanted to comment on this, Gorik?
Yeah, I'm a little more optimistic on building the case, on finding facts and figures. There is already a lot of figures available at this time. In fact, there are also the federal, the KCE study we can use and build upon. We did an effort ourselves as a federation to figure out how many money is needed. But there is another issue, I think, that is that when you get the work done and you've got the cost effectiveness arguments, the business case, this is a question of ownership. We've got in our country 7 different ministers who are responsible for the business case. So that's a problem. Because I read in the book that at some point in the EIPT program, there was a co-funding and there was a spread of political departments and a political co-responsibility, and it didn't work. So I'm an optimist, you have to believe me, but if that is truly a recommendation from you, Professor, that you should do it by only one owner of the business case, only one responsible, then we have a really great problem in Belgium, because responsibilities are co-funded and divided over several ministers, and in our country there will be no other way at this point than to do it in a complex way.
Well, yeah, I totally agree with that point. So that's yet another reason why mental health has to fight an uphill battle, so to speak, because of many of the benefits will be diverted to other departments. So that is next to the fact that there is stigma and less solidarity with mental health and with physical health, and there's many arguments why it's more difficult. That's another reason I think why you should make the cost effectiveness case as strong as possible, because it's going to be there's going to be many battles to be fought, and it's probably a very important argument in overcoming all these issues.
Two brief comments maybe from you, Harmen?
You want to start?
No, it's fine.
Yeah. I can only acknowledge the fact that it's not easy to work in the federal government regarding mental health, and the fact that you have to constantly talk and agree consensus, not consensus, with other parties, other governments. On the other hand, there are a lot of federal states in the world. Of course, we are not the only one, and we are not the only one with big responsibilities on a regional level. For this pilot, nonetheless, we were more or less the only responsible government, more or less. So I think it is a difficulty in Belgium. I mean, kicking in an open door, but I think it's possible though. I think there are ways to find a way to implement a good business case towards a general policy, not just a pilot. If we don't believe that, then I could stop my job. So.
Okay, I think we have to close the discussion. Before ending, I wanted to say, during the discussion, I had this image of this being the new Belgian David Clark, and this being the new Belgian Dr. Laird. Wouldn't that be a great couple? And wouldn't you agree, David, that with all the other experts here, both from political offices and from all the other organizations, that this would be the team?
Well, absolutely. I mean, you've got a dream team here, haven't you? And I have to say that when we started lobbying, we didn't have so many political representatives coming along and listening as well. So I think you've got a bright future.
Okay. Thanks to all the panelists.
Okay, as I promised, I would be back for some very intense last 10 minutes. As you may have seen, this event was an initiative by Tina and me and professors of diverse universities in Flanders. You already met Dirk Hermans, who moderated the event, and Pierre Philippot from the University of Louvain-la-Neuve. But there's also